Hello everyone. Welcome to second lecture in prosthodontic dentistry for third year students. Today we're going to talk about partial edentulism, etiology, clinic classification, change in the maxillofacial region with partial edentia, examination of patients, evaluation of abutment teeth, the planning of prosthetic treatment of partial edentia, biological and clinical indication for treatment with partial fixed dentures, and design feature of partial fixed dentures. Edentulism or toothlessness is the condition of being toothless to at least some degree. In organisms that naturally have teeth, it's the result of tooth loss. Loss of some teeth is called partial edentulism, whereas loss of all teeth is called complete edentulism. Edentulism is a condition which can have multiple causes. In exceedingly rare cases, toothlessness may result from the teeth not developing in the first place. It's anodontia. However, in most cases, it's a result of permanent tooth extraction in adulthood. This may or may not be due to dental caries, periodontal disease, trauma, or other pathology of the face and mouth. And thus, under 45 years of age, dental caries is considered to be the main cause of toothlessness, whereas periodontal disease is a primary cause of tooth loss in older age group. Clinic. Patients make various complaints. In the absence of incisor and canines, complaints of aesthetic deficiency, speech disorders, splashing of saliva during conversation, and the inability to bite of food predominate. Patients who lose posterior teeth complain of chewing disability, frequent on the inconvenience of chewing injury and soreness of the gingival margin. In the case of absence of premolar on the upper jaw, there are frequent complaints of anesthetic. When collecting anamnestic data, it's necessary to determine the cause of tooth extraction, as well as to find out whether orthopedic treatment was previously performed and with the help of redesign of dentures. During external examination, as a rule, there are no facial symptoms. If there are no incisors and canines on the upper jaw, then there may be some sinking of the upper lip. In the absence of a significant number of teeth, retention of the soft tissues of the cheeks and lips is often observed. In case where there is a missing part of the teeth on both jaws without preserving the antagonist, that is, with an unfixed bite, the development of angular cheilitis is possible. With swallowing movement, a large amplitude of the vertical movement of the lower jaw is observed. During examination on the tissues and organs of the oral cavity, it's necessary to determine the type of defect and its extent, the presence of antagonizing pairs of teeth, the condition of hard tissues, mucosa, and periodontal tissues, and evaluate the occlusal surface of dentures. In addition to the examination, palpation, probing, tooth stability are determined. An X-ray examination of the periodontal tissue of abutment teeth is mandatory. On the slide, you see leading symptoms in the clinic for defects dental rows. First, violation of the continuity of the dental arch. Second, disintegration of the dentition into independently acting groups of two types of teeth, functioning and non-functioning. 3. Functional overload of the periodontium of the remaining teeth. 4. Deformation of the occlusal surfaces of the teeth. 5. Malfunction of the chewing functions and speech. 6. Change in the temporomandibular joint due to the loss of teeth. 7. Malfunction of masticatory muscle function. 8. Violation of aesthetic norms. Moreover, first, second, and fifth points always accompany partial loss of teeth. Other violations may not occur or it may not occur immediately, but due to ongoing tooth loss or periodontal disease. Violation of the continuity of the dentition is caused by the appearance of defects. A defect in the dentition should be considered the absence of 1 or 30 teeth in it. Widespread in Western countries, Europe, America, and our country is the Kennedy classification. The author divided all the defects of the dentition into 4 main classes. Class 1. Bilateral edentulous area located posterior to the remaining natural teeth. There are no posterior teeth in the two edentulis area. These are called free end saddles due to the lack of an abutment posterior tooth. Class 2. Unilateral edentulis area located posterior to the remaining natural teeth. The patient has missing posterior teeth only on one side of the dentition. Class 3. Unilateral edentulis area with natural teeth both anterior and posterior to the area. There are no free end saddles due to the presence of an abutment posterior tooth on one side of the jaw. This class is most commonly seen on patients. Class 4 is single but bilateral edentulis area located in the anterior of the remaining natural teeth. It's rarely seen because patients usually lose the posterior teeth first. The Kennedy class 4 may be due to an accident or knocked out front teeth. The main advantage of the Kennedy classification is logic and simplicity, which make it possible to immediately imagine the type of defect and the corresponding design of the prosthesis. The first three classes may have subclasses defined by the number of additional dental defects. There is not counting the main class. Applegate in 1954 supplemented Kennedy's classification by proposing 8 rules for its application. First, the definition of a defect class should not precede tooth extraction, as this may change the initially established defect class. Second, if there is no third molar that should be replaced, then it doesn't count towards classification. If there is a third molar that should be used as a supporting tooth, then it's taken into account in the classification. 4. If there is no second molar that should be replaced, then it doesn't count towards classification. 5. The defect class is determined by the location of the toothless area of the jaw. 6. Additional defects are considered as subclasses and determined by their number. 7. The extent of additional defects is not considered, only their number is taken into account, which determines the number of the subclass. 8. Class 4 has no subclass. Toothless area lying posterior to the defect in the area of the anterior teeth determines the class of the defect. Using this classification, you can quickly make a choice between a prosthesis based on 2 teeth according to the type of bridge prosthesis for defects class 3 and the support on the teeth, mucosa and underlying bone for defects class 1. Kennedy's classification, like other anatomical and topography classification, doesn't give an idea of the functional state of the dentition, which is important for choosing the design of clasps and the way of distributing the load through them between the abutment teeth and mucosa of the alveolar process. When choosing design of the prosthesis, the following factors must be considered. The functional condition of the periodontium of the abutment teeth and teeth antagonists, functional ratio of antagonizing groups of teeth, functional ratio of upper and lower jaw, functional condition of the mucosa of the toothless area of the alveolar process, the shape and size of the toothless area of the alveolar process. The most common type of morphological and functional correlation of the dentition includes the following. First, there is a continuous dentition on the opposite jaw. Second, on the opposite jaw there are defects of the same class, can be symmetrical, asymmetrical, or cross-located. Third, on the opposite jaw there are defects of various classes, for example, combination of first and fourth, combination of second and fourth classes. Fourth, all teeth are absent on the opposite jaw. The functional ratio of the dentition can be equal and unequal, with a predominance of the strength of the abutment teeth or with a predominance of the antagonizing teeth stretch. Kennedy classified defects of only one arch, and when choosing the design of the prosthesis, it doesn't take into account the type of defects on the opposite jaw and the occlusal ratio of the remaining group of the teeth. The functional correlation of dental rows in different classes of defect is not the same, and depending on their combination on the upper and lower jaw after prosthetics, a new functional ratio of dentition is created. It can be favorable or unfavorable in relation to the distribution of the load falling on the supporting tissue. Despite the fact that the dentition consists of individual elements, it's combined into a whole both morphologically and functionally. A unity of the dentition is provided by the alveolar process and interdental contacts. With age, contact points are erased, turning into platforms, but the continuity of the dentition is preserved due to the mesial shift of the teeth. As a result, the dental arch may shorten by 1 centimeter with age. The chewing pressure that occurs in any part of the dentitions fall not only to the root of this group but through the interdental contacts, as a chain is transmitted to other teeth. A similar mechanism for the distribution of chewing pressure protects the teeth from functional overload. In addition, interdental contacts protect the marginal periodontum from injury by a hard foot. First strike on the unity of the dentition is applied by removing the first tooth, and its severity depends on what kind of tooth. This is the removal of a part of the teeth. The morphological and functional integrity of the dental arch ceases to exist, which at the same time splits into independently acting groups or into a series of individually standing teeth. Some of them have antagonists and can bite or chew food, forming a functioning group. Others are deprived of antagonists and don't participate in the act of chewing. They form a non-functioning group. In this regard, the teeth of a functioning group begin to perform a mixed function, experiencing pressure that is unusual both in size and direction. For example, anterior teeth designed for biting of food and not for rubbing it have to take a large load which is not always adapted to their periodontum, and this can lead to functional overload. Gradually, the cutting edge of the frontal teeth raised, instead they formed a chewing pad, and it reduces the height of crowns and consequently to a decrease of vertical dimension and lower third of the face. This in turn causes the reconstruction of the temporomandibular joint and the function of the chewing muscles. In addition, chewing pressure, unusual in size and direction, can lead to functional overload of preserved teeth if there is no timely prosthetics. The simplest example of a traumatic occlusion accompanied by functional overload is an increase in the intraalveolar height of a single crown or bridge. At first it makes you feel discomfort, which later passes, but over time there is a pathological mobility of the teeth, marginal periodontitis, bone resorption detected by radiography of the alveolar process. Functional overload of teeth with defects in the dental arch occurred due to changed conditions for the perception of chewing pressure, reduction of the number of antagonizing teeth, or damage to the supporting apparatus of the teeth as a pathological process. In small defects, functional overload is not felt, since the preserved teeth without special stress for their periodontum make up for the lost function. With the expansion of defects, the functioning of the dentition deteriorates, its overload increases. This, in turn, causes the reconstruction of the chewing apparatus, its adaptation to the new functional condition. In the periodontum, compensation phenomena are accompanied by increased blood circulation by involving a large number of capillaries in the bloodstream, increasing the thickness and number of sharper fibers. Bone trabecular discs become more durable. However, the body's ability to readjust in general and periodontum in particular are not unlimited. Therefore, the functional load cannot exceed a certain level without the degeneration of the supporting tissues of the tooth as a result of circulatory disorders. In this regard, the resorption of the alveolar walls appears, the periodontal gap expands, the movement of the tooth becomes noticeable to the naked eye. The ability of the periodontum of the teeth to withstand increased functional load depends on its reserve force. Under the reserve force of periodontum, understand the ability to adapt to a change in functional stress. The periodontum of each tooth has its own reserve of reserve force. Determined by a general condition of the body, the periodontal surface, the width of the periodontal gap, the ratio of the length of the crown and root. Persons avoiding solid food, especially children, have weaker periodontum compared to those who eat rough foods. Our ancestors eating raw food constantly trained periodontum. Currently, processed and ground food is being eaten, which excludes periodontal training. Reserve forces change with age. It must be assumed that this is primarily due to a changing in the functional capabilities of the vascular system of the body in general and periodontum in particular. Along with this, the ratio of the sub and supracrustal part of the tooth change with age. Changing in crown size changes the force falling on the root, and the decrease in the height of the tubercles due to abrasion makes chewing movements smoother. Recent circumstances compensate for the fall in reserve forces due to circulatory disorders associated with age. General and local disease can also affect reserve forces. When the adaptive mechanisms of the periodontum are not able to compensate for acute or chronic overload of the teeth, the chewing pressure turns from a factor that simulates metabolic processes into its opposite, causing the phenomenon of dystrophy in the periodontum. In the clinic of partial loss of teeth, a new phenomenon occurs, a symptom of traumatic occlusion. Closing of the teeth in which a healthy periodontum feels chewing pressure that exceeds the limit of its physical endurance, we call it primary traumatic occlusion. Overloading of teeth with defects in the dental arch develops in certain orders. First of all, the teeth that hold the intraalveolar height are subject to overload. In this case, a typical picture of the primary traumatic syndrome develops: tooth mobility, atrophy of the bone and gums, exposure of the neck of the tooth, and as a result, the appearance of pain during the reception of hot and cold food. After the loss of these teeth, the focus of traumatic occlusion is transferred to another group of the teeth that hold the intraalveolar height, and thus in this way it seems to move along the remaining dentition. Pathological occlusion. The specialized literature, they designated such a closure of the teeth in which there is a functional overload, that is, the term pathological occlusion was identified with the term traumatic occlusion. This definition of pathological occlusion should be considered inaccurate, since there is a significant difference between pathological and traumatic occlusion. For example, several forms of open bite are accompanied by serious violation of chewing function. Reducing the useful chewing surface doesn't provide mechanical processing of food, so some patients rub it with their tongue. At the same time, there are no symptoms of functional tooth overload. Thus, there is a need to give another, more accurate definition of pathological occlusion. Under pathological occlusion should be understood such clothing of the teeth in which there is a violation of the shape and function of the dentition system. It appears as a functional overload of teeth, violation of the occlusal plane, pathological irascibility, trauma to the teeth of the marginal periodontum, blockage of movements of the lower jaw. Traumatic occlusion is a form of pathological occlusion. Pathological occlusion refers to traumatic occlusion in the same way as the whole refers to the particular. Types of traumatic occlusion. Functional overloading of teeth has different origins. It can occur as a result of changed conditions in the oral cavity, as a consequence, malocclusion, partial loss of teeth, deformation of the occlusal surface of the dentition, mixed function of the frontal teeth, pathological irascibility, mistakes in prosthetics, bruxism, acute and chronic periodontitis, osteomyelitis, and jaw tumors. Functional overload with partial tooth loss occurs due to a change in the distribution of masticatory pressure due to a violation of the continuity of the dentition, a decrease in the number of teeth in contact with their antagonist, the appearance of a mixed function, deformation of the occlusal surface caused by tooth movements. When an unusual functional load falls on the healthy periodontum, we are talking about primarily traumatic occlusion. In another case, the chewing pressure becomes traumatic not because it has increased or changed direction, but because periodontal disease have made it impossible for it to perform normal functions. We call this traumatic occlusion secondary. The separation of primary and secondary traumatic occlusion has its own reasons. With traumatic occlusions, a vicious circle is created in the dental system. Arising for any reason, periodontal disease generates functional overloading, and traumatic occlusion in turn enhances the disease of periodontum. In this vicious circle, it's necessary to find the leading link, reveal the cause and effect relationship, and outline pathogenetic therapy. This is why it's useful to distinguish between primary and secondary traumatic occlusion. Mechanism of traumatic occlusion. In the pathogenesis of traumatic occlusion, functional overload should be distinguished by its magnitude, direction, and duration of action. An example of a primary traumatic occlusion accompanied by an increase in functional load is an increase in the height of the bite on a single crown, seal, or bridge. At first, this causes a feeling of discomfort, a feeling of a tooth that the patient didn't notice before, and then pain is added. With a slight increase in the height of the bite, these symptoms of traumatic occlusion disappear over time, as the periodontum adapts to the changed function. When increasing the height of the bite will be significant, then the discomfort and pain is followed by pathological mobility of the tooth, gingivitis, and then dystrophy of the bone detected by radiography of the alveolar process. This simple example shows how primary traumatic occlusion leads to the development of a complex clinical picture, which could be called primary traumatic syndrome. Primary traumatic syndrome is characterized by a combination of two symptoms, traumatic occlusion and periodontal disease. With this formulation, traumatic syndrome becomes a complex concept that reflects a violation of both the function and structure of the organ. Primary traumatic syndrome, being a logical development of primary traumatic occlusion, has a certain clinical characteristic. It's characterized by pathological mobility of tooth, exposure of its roots, gingivitis, atrophy of bone, and tooth displacement. Periodontal disease that occurs due to functional overload may stop and then recovery occurs. In other cases, it's irreversible. The removal of overload doesn't eliminate the disease, and the patient subsequently loses teeth. The functional load can vary not only in size and direction but also in duration. Those people who suffer from night grindings, epilepsy, along with an increase in the force of pressure, increased duration of occlusive contacts. An increase in the clothing time can also be noted on the front teeth with their mixed function, when instead of cutting-edge white chewing surface appears. The time of occlusal contacts is lengthened in some types of abnormalities, for example, with a deep bite. This type of closing extends the incisor path time. Multiple contacts in the lateral part of the dentition when clothing the mouth occurs a little later than it's happened with normal overlap, so that the lower front teeth experience pressure for a long time. For this reason, the periodontal capillaries remain bloodless for a long time than is typical for their physiology. Periodontal anemia occurs, and as a result there is a violation of its nutrition. This is the mechanism of periodontal disease in traumatic occlusion, when the functional load increases over time. The basis of functional overload is rarely only an increase in chewing pressure or a change in its direction and time of action. More often there is a combination of these factors. The clinic of functional overload is especially pronounced on the molars and premolars, which tilt towards the defect and dragging through the internal ligament and the adjacent teeth. In children and adolescents, unusually functional load is easily compensated by the reconstruction in the alveolar process, and often the second molars, after removing the first, come close to the premolar due to body movement, remaining stable. In adults, the tilt of the tooth toward the defect is accompanied by the formation of a bone pathological pocket. On the movement side, the exposure of the neck and the appearance of pain from temperature stimuli. Analysis of occlusion in such a position of the tooth always reveals a sign of unusual functional load, since contact with the antagonist tooth is preserved only the distal ridges. These signs are pathognomic for function overload. Functional overload, which develops with dental defects, doesn't occur immediately. Partial loss of the teeth as an independent form of lesionless dental system is accompanied by pronounced adaptive and compensatory processes. Subjectively, a person who has lost one, two, or even three teeth may not notice chewing disorders. However, despite the absence of subjective symptoms of the lesion, significant changes occur in dental system which depend on the topography and size of the defect. In this case, an important role is played by the number of pairs of antagonists that hold the height of the bite when chewing and swallowing and take on the pressure developed during the contraction of the chewing muscles. Especially fast functional overload develops with the formation of bilateral end defects that occurred against the background of a deep bite. In the area of teeth that don't have antagonists, various changes of morphological and exchange character occurs in the tissue of the teeth, periodontum, and alveolar process. The periodontal gap of teeth devoid of antagonists is narrowed. In the periodontum, the volume of loose connective tissue increases. Collagen fibers acquire a more oblique direction than in the periodontum of functioning teeth, and sometimes they are located almost longitudinally. Hypersymatosis is often observed, especially in the area of the root tip. Deformation that occur after the appearance of dental defects have an age characteristic. They develop most rapidly in childhood. This is due to the high plasticity of the bone of the alveolar process and the high reactivity of the child's body. So, in children, after the removal of permanent teeth, most often the first molar, there is a rapid movement of the second molars. Their mesial titil, and as a result, severe occlusion violation in the area of the defect and possibly violation of the development of the jaws. At the same time, it's difficult to exclude the influence of occlusal disorders on the muscle function and the temporomandibular joint. This conclusion is very important for planning the preservation of the deformation. It's obvious that you should not rush to remove permanent teeth and take all measures to preserve them. If it's not possible to save the tooth, then the use of appropriate prosthesis is necessary in childhood. As the plasticity of the jaw bones decreases, the rate of deformity development decreases, but in adolescence it remains quite significant. The preventive orientation of dental therapy at this age remains, however, in the somewhat different form. After removal of the permanent first molars, the patient is subject of medical supervision with mandatory examination once a year. When the first ones appear, signs of tooth movement and occlusion disorders require immediate prosthetics. When removing two or more teeth or even one incisor canine, prosthetics are also performed immediately. Similar tactics should be followed in other age groups up to about 30-35 years. Knowledge of the feature of deformity development after tooth extraction allowed us to correctly solve the problem of prosthetics for patients with small defects in the dentition, in particular those that occurred when the first molar were removed. Usually, indications for prosthetics were considered only with regard of violation of function and aesthetics. Since those after the removal of the first molars are small and the operational trauma during the preparation of teeth under fixed prostheses are significant, the evidence in favor of refusing prosthetics was. But this decision was wrong about the individual's young age, since the probable possibility of deformity development was not taken into account. If you remember the danger of this complication, it will become clear that in childhood, prosthetics should be carried out immediately. In this situation, it's of a purely preventive nature. In adolescent, prevention remains important along with treatment. Only in the older and elderly ages, when the danger of deformity disappears, the preventive focus recedes into the background and the first place is taken by therapeutic goals. Thus, in the light of data on age-related deformities, the issue of prosthetics for patients of different ages after removal of the first molar is resolved. With defect in the dentition during their closing, there is a pressure that displaces the tooth in one of the four directions. This disrupts the articulatory balance, creates conditions under which individual components of chewing pressure begin to act as traumatic factors. Relative stability of the physiological balance according to Katz. Katz defines the physiological balance of the chewing apparatus as relative stability of the shape and function of the dental system, chewing muscles, and surrounding hard soft tissues. Stability which persists for a long time without noticeable fluctuations. The relative stability of the chewing apparatus may be disturbed by endogenous and exogenous causes, in the particular when the tooth is removed, and may be reestablished by compensating for the physiological balance. Again, the created relative stability of the chewing apparatus is established at a new level. If you lose another one or more teeth, the relative stability of the chewing apparatus is again violated, and so on units the compensatory possibilities are exhausted. At the same time, the chewing function decreases to a greater or less extent. In managing the activity of the temporomandibular joints, the muscles play a crucial role. Of these, the lateral one has a specific function, the pterygoid muscle, whose harmonious work together with the articular disc and the articular head is a prerequisite for the proper functioning of the joint. The articular disc associated with the lateral pterygoid muscle coordinates and stabilizes the movement of the lower jaw. The ligaments of the joint at the same time, and you play only a supporting role. The formation of the joint is directly influenced by the bite and the nature of articulation. Violation of the normal activity of the joint with partial loss of the teeth can be associated with a change of the distribution of chewing pressure, a decrease in the interalveolar height, or the appearance of unusual excursion of the lower jaw due to the deformation of dentition. These three factors ultimately cause functional overload of the joint. Functional overload of the temporomandibular joint. In order to understand this issue in more detail, it's necessary to imagine the condition for the distribution of masticatory pressure in the physiological bite with its multiple contacts during central and lateral occlusion. The chewing pressure in this condition is evenly distributed on the dental rows of the upper and lower jaw and joint. Molars and premolars taking on the main pressure, thus carry out a kind of lateral protection of the joint. With the loss of it, all the force of muscle contractions fall on the front teeth and joint, causing them to overload. After the loss of the lateral teeth, the chewing center is transferred to the frontal teeth. With a straight or orthodontic bite with a healthy periodontum, the front teeth and their alveolar process can manage with increased stress, taking on the entire weight of the functional load along with the joint. The height of the bite in this case may not change. With a deep bite after the loss of support on the side teeth, further sliding with acute lower front teeth on the palatine surface of the upper ones until contact with the gingiva. A deep bite will turn into a traumatic one. A similar phenomenon can be observed in periodontal disease. Increased functional stress on the front teeth cause their overload at subsequent fan-shaped divergence or pathological erasure, which will result in a decrease in the interalveolar height. It's also possible to lose the cutting contact while the functional overload of the joint increases as the support on the front teeth is lost. Lowering the interalveolar height causes changes in the position of the articular head. It departs from the base of the posterior slope of the articular tubercle and approaches the posterior wall of the articular cavity. The latter therefore meets with an unusual load for it. When the dentition is formed, complex violations of occlusal relations occur. In some cases, they interfere with the extension of the lower jaw forward and then the predominance of hinge movements on the side of the lesion and the displacement of the lower jaw at the beginning of opening the mouth on the 6 sides comes to the fore. In other cases, multiple contacts disappear with lateral occlusion. In both cases, as a result, there is an overstrain of the joint and increased load leads to its structural adjustment. At first, it is adaptive. When functional stress increases, structural changes acquire pathological properties and in turn cause distortion of the movements of the lower jaw. The four-seat position of the articular head may not always result in compensatory reconstruction. Apparently, compensatory adjustment is possible only at a certain overload force at a certain voltage. The diversity of the clinical picture of partial tooth loss has a significant impact on the choice of treatment method. After determining the class of defect of each dentition separately, it's necessary to establish the relationship between the remaining teeth in the state of central occlusion and the relative physiological rest of the lower jaw. For this purpose, the central occlusion is determined. It's necessary to examine whether the height of the lower part of the face has not changed, whether there has been a distal displacement of the lower jaw, and also the cordon of the position of the preserved teeth in relation to the occlusal plane. Various deviations are particularly well detected when the correct height of the lower part of the face is set on the occlusal rollers in the position of central occlusion and indicate the development of complications. Identification of a dental defect, determination of its class, as well as the nature of the patient's complaints allow us to speak with certainty about the presence of this nasological form. During the diagnostic process, it's necessary to differentiate the defect, adentia, and retention. Adentia is characterized by undevelopment of the alveolar process and its flattening due to the absence of bud of the teeth. It's often combined with diastema and tremors anomalies in the shape of teeth and enamel. Retention can be detected by examination, palpation of the alveolar process, but with mandatory radiological confirmation. The uncomplicated form of the dentition defect should be differentiated from the accompanying combined disease. Viewing periodontal disease and deformities of the dentition will lead to an erroneous choice of treatment method. In cases where the defect of the dentition is combined with pathological irreversibility of the hard tissues of the crowns of preserved teeth, it is important to determine whether or not there is a decrease in the height of the lower third of the face. This significantly affects the entire treatment plan. The diagnosis in this case changed, a defect in the dentition complicated by pathological irritability and a decrease in occlusal height. In order to treat patients with dental defects, bridges, removable dentures, and clasp prostheses are used. With their help, you can fully eliminate phonetic and aesthetic deficiencies, morphological disorders in the dental system, and restore function. When choosing the design of the prosthesis and supporting teeth, you should take into account the class and extent of the defect, the periodontal condition of all remaining teeth, and the state of the chewing muscles. The type of bite and certain professional habits of patients can significantly influence the final design of the treatment device. Partial fixed dentures or bridges. Bridges are classified according to various characteristics by material, by the nature of the attachment, by the method of manufacture, in relation to the intermediate part of the alveolar process, by the design of the supporting part of the prosthesis, by location of supporting teeth, by the design of the intermediate part of the prosthesis. In addition to the positive qualities, the bridges have the following deficiencies: the need to prepare teeth for supporting elements, the possibility of functional overload of periodontium of the teeth and the wrong choice of design, the irritating effect of an artificial crown to the marginal gingiva, unsatisfactory aesthetic qualities, difficulty in hygiene care of the prosthesis due to the non-removable structure. Indication for the use of bridge in the orthopedic treatment of patients with dental defects and the choice of their design are determined mainly by the following factors: the size and topography of the defect, its localization, the condition of hard tissues and periodontium of supporting teeth and their antagonist, as well as occlusal relationship. Defects in the dentition are conventionally divided into small, in case of absence from 1 to 3 teeth on the jaw, medium, in the absence of 4 to 6 teeth, and large in the absence of more than 6 teeth. The question of replacing small defects in the area of posterior teeth and to this day remains controversial as can be seen from the above description. The need to replace one missing tooth is solved not only depending on the size of the defect but also on its localization. So, if a person is lost a frontal teeth, then aesthetic indications come to the fore, and regardless of age, urgent prosthetic are necessary. The method of choice can be implants, fixed bridges, partial removable dentures, including those with a metal base. The possibility of treatment with bridge is based on the general biological position about the presence of physiological reserves in human tissues and organs. This allowed us to put forward the conception of periodontal reserve forces, which is confirmed by the analysis of the result of the study of periodontal endurance to pressure gonatodynamometry. The limit of the periodontal endurance to pressure, their salt loads, an increase in which leads to pain, is equal to 40-50 kilograms for premolars and 60-75 kilograms for the molars. However, in natural conditions, when biting and chewing food, a person doesn't develop a force that causes pain. Therefore, in natural conditions, part of the periodontal endurance to load is constantly realized, and part is a psychological reserve used in extreme conditions, in particular during prosthetics. The size and direction of the load on periodontium supporting teeth are directly dependent on the state of the teeth antagonist. In natural conditions, the size of the food lump between the teeth doesn't exceed the length of 3 or 4 teeth. So we can assume that the maximum load, for example, in the area of chewing teeth, depends on the total endurance of the periodontal premolar and 2 molars. In the area of the frontal teeth, 2 central and 2 lateral incisors. Indication for the use of fixed prostheses are included defects in the dentition that is limited on both sides by the teeth. Long-term clinical observation and study of the physiology of chewing have established that the grinding and chewing of food occurs on two three teeth of the upper and lower jaw. Therefore, when replacing the defect of two posterior teeth, it's enough to fix the breach on two healthy teeth. If the defect was formed from the loss of more than two teeth, the prosthesis may also have tooth support, for example, molar and canine. This provision applies only to a posterior group of the tooth and a canine located at the junction of two functionally differently oriented groups of the teeth. These defects located in the anterior part of the dentition bridge are shown even with the loss of all four incisors, provided of course that the periodontium of canines are preserved. Whereas the approach to prosthetics for defects in the anterior and posterior section of the dental arch is explained by the features of the functions of these teeth. Front teeth, like they are known to be adapted to biting of food. The force that occurs in this case is less than the force developed on the posterior teeth, and it is transmitted along the long axis of the tooth that is more favorable. Therefore, the canines being a support will not experience functional overload. A special role in the development of functional overload is played by violation of the occlusal relationship of the bridge with the antagonizing teeth. When swallowing, when the teeth close in the position of central occlusion, all the force of the contracting masticator muscles will fall on the points that increase the bite. The point focus of traumatic occlusion is dangerous for the natural antagonist, who finds himself in particularly unfavorable conditions. In connection with the bilateral structure of the dentition system, it seems that each tooth is able to withstand the additional function of another tooth of equal power without causing damage to the periodontal tissue. In other words, the periodontal area of each tooth under normal condition when the dental arch is intact realizes only half of its inherent resistance to chewing pressure. The other half is hidden potential and manifests itself under changed conditions due to the loss of adjacent teeth. Thus, the limit of compensatory periodontal capacity of each tooth is determined by the double force of the chewing load. Determining the chewing load in the clinic is quite a difficult task. Using the gonadodynamimeter mainly determines only the strength of the vertical chewing pressure, but not the entire loads as a whole. Basic design principle of bridge. When designing bridge, certain principles should be followed. According to the first principle, supporting elements of a bridge and its intermediate parts should be on the same line. The curved shape of the intermediate part of the bridge prosthesis leads to the transformation of vertical and horizontal loads into rotating ones. The loads is applied to the most prominent part of the body of the bridge. If you draw a perpendicular to the straight line connecting the long axis of the supporting teeth from the most distance or J point of the prosthesis body, it will be the arm of the level that rotates this prosthesis under the action of chewing load. The amount of rotating force is therefore indirect depends on the curvature of the body of the bridge prosthesis. Reducing the curvature of the intermediate part or it will help to reduce the rotation action of the transformed chewing load. The second principle is that when designing a bridge prosthesis, you should use supporting teeth with a not very high clinical crown. Horizontal load value is directly proportional to the height of the clinical crown of the supporting tooth. The use of supporting teeth with high clinical crowns and shortened roots is especially harmful for periodontal disease. In this case, there is a great danger of rapid transition of the compensate form overload in decompensated with the appearance of abnormal mobility of the supporting teeth. Similar condition occurs in alveolar process atrophy when there is an increase in the height of the clinical crown of the tooth due to reduction of the intraalveolar part of the root. At the same time, it should be borne in mind that with excessively low clinical crowns, the construction of a bridge-like prosthesis is also difficult due to the rigidity and reduction of the area of the body's fit to supporting elements. Especially often, the connection is destroyed in soldered bridge dentures. The third principle assumes that the width of the masticatory surfaces of the body of the bridge prosthesis should be less than the width of the masticatory surface of the replaced teeth. Since any bridge prostheses are already noted functions for due to reserve forces of the periodontal support teeth, the narrowed chewing surface of the body reduces the load of the supporting teeth. Moreover, it's advisable to take into account the presence of antagonizing teeth and their appearance, natural or artificial. If the pressure is concentrated closer to one of the supporting teeth due to the loss of some of the antagonists, then the body of the prosthesis in this place may be narrower than in other areas. Thus, the chewing surface of the body of the bridge prosthesis is made narrow to avoid excessive functional overload. And the amount of narrowing in certain areas is determined individually in accordance with the features of the clinical picture. An increase in the width of the chewing surface of the intermediate part of the bridge prosthesis leads to an increase in the functional overload of the supporting teeth, not only by increasing the total area that receives chewing pressure, but also by the appearance of rotational force along the edge of the prosthesis body that goes beyond the width of the supporting teeth. The fourth principle is based on the fact that the amount of chewing pressure is inversely proportional to the distance from the point of its application to the supporting tooth. Thus, the closer the load is applied to the supporting tooth, the greater the pressure falls on this supporting tooth, and conversely, when increasing the distance from the place where the load is applied to the support tooth, the pressure on this support tooth decreases. The fifth principle is related to the need to restore contact points between the reference points element of a bridge prosthesis and natural teeth standing next to each other. This allows you to restore the continuity of the dental arch and contributes to a more uniform distribution of chewing pressure, especially its horizontal component among the remaining teeth in the oral cavity. Especially, it's important to observe the principle with a well-defined sagittal occlusal curve when transformed from vertical horizontal loads tend to tilt the supporting teeth in the medial direction. The contact points correctly restored by the supporting elements of the bridge prosthesis will transfer part of the horizontal force to the natural teeth standing next to it. This helps to maintain the stability of the supporting teeth and prevent their tilt in the medial direction. The sixth principle provides for the component construction for bridge from the point of view of fusion of normal occlusion. There are two groups of patients. The first group includes patients whose prosthetics task is to restore occlusal relationship in the area of the defect with careful modeling of the occlusal surface of the bridge prosthesis first into the patient's exciting functional occlusion. Here, first of all, you should take care of preventing premature contact, reducing the intraalveolar pressure distance and functional overload of the periodontum after prosthetics. The second group includes patients who need not only prosthetic but also simultaneous change in functional occlusion within the entire dentition. This is necessary for partial loss of teeth, increased irreversibility, periodontal disease, anomalies of occlusion complicated by partial loss of teeth. Common to all these pathological conditions is a decrease in the intraalveolar distance. Thus, the second group of patients requires more complex prosthetics, taking into account deep changes in the occlusion of the dentition. Seventh principle, it's necessary to design such bridge that will meet the requirements of aesthetic to the maximum extent. For this purpose, the most aesthetically advantageous facing materials are used, as well as the supporting elements and the intermediate part of the prosthesis are designed to ensure reliable fastening of the facing made of plastic, porcelain, or composite material. Application and fixation of the bridge prosthesis. The last clinical stage is to fix the bridge prosthesis on the supporting teeth. This stage is very important. Despite careful preparation of supporting teeth, bridge prosthesis is not always possible to apply due to the minor inaccuracies that violate the parallelism of the supporting teeth. The prosthesis should be easily inserted to its place. This is extremely important, otherwise these teeth will be injured. This is why you should not insert bridge with forces, but rather sand the obstructing part of the supporting teeth, and then the prosthesis will be easily placed in its place. Both crowns and other supporting elements should be well stored in advance to their support points even during fitting them, but there may be some change in their position when removing the impression, and then they don't sit as perfectly as they did before during fitting. In such cases, the prosthesis sometimes doesn't even overlap in its place. Sometimes the reason is that the prosthesis is not imposed an accurate spike part of the prosthesis. In such cases, the prosthesis needs to unsolder the reshoot impression with crowns in the mouth and resolder them with the body of the prosthesis, but under a new impression model. The part of the prosthesis adjacent to the gingival should not be sharp, cut into and press on soft tissues injure them. These complaints are often ignored by the patient since it's believed that the pain caused in such cases when the prosthesis is applied with pads in a few days and everything will be fine. And indeed, after a week or two, patients stop feeling the excess parts that are embedded in the gum, but the irritation doesn't stop, and after a certain period of time, more or less, depending on various conditions, there are such phenomena that require immediate removal of the prosthesis. After removing the prosthesis, you are usually amazed how the patient could tolerate its presence in the mouth for so long. The entire area occupied by the prosthesis ulcerates and bleeds. All this can be avoided by carefully storing the prosthesis and its supporting parts to the support points and the gingival to which it is adjacent. In general, it should be taken as a rule that the crown or bridge should be easily and painlessly superimposed or its support points, and pain should not be felt when closing the jaw when pressing on the chewing surface of the prosthesis. The bridge shouldn't interfere with articulation in any part of it, just like that, but most often there are serious omissions. The fact is that usually completely healthy teeth are chosen as a support for the prosthesis, which are extremely sensitive to grinding. Meanwhile, the chewing surface of the supporting teeth should be sanded to the thickness of the crown. If you make into account, note that the supporting teeth of the bowl are molars and premolars, it will become clear that these teeth, which have well-developed bumps, are not so easy to process the sanding if the pulp is alive. This is the reason for the frequent increase in bite in bridge. It should be pointed out that even the smallest increase in the bite leads to trauma of the periodontium supporting teeth, since the entire force of pressure at the same time presses exclusively on these teeth, and they eventually loosen and become sensitive when pressed. In addition, in place where the bite is increased, the antagonists wipe the crowns until the chewing surface of the teeth is exposed, which is again harmful to them. Places are formed that contribute to the retention of food residues that gather between the crown and the tooth, often even pain from cold and heat. When the prosthesis is placed on the supporting teeth, the occlusion is carefully checked again. All points that interfere with the correct closing of the dental rows are eliminated by metal polishing. If the patient feels some discomfort, the prosthesis fixed by temporarily cement and left in the oral cavity for 1-2 days, after which this phenomenon completely disappear. If the complaints don't disappear, it's necessary to check again the occlusions, the length of crown, condition of periodontum. For fixing the bridge, you need accurately dry the metal crowns and supporting teeth with alcohol or warm air. Special phosphate cement for fixing bridge is mixed up and applied into the crowns. The supporting teeth are covered with cotton pads and changed from time to time, keeping the teeth dry up to before the prosthesis is applied and the cement hardens. Then extra cement is carefully removed and the edge of the crown and the gingiva are smeared with Vaseline or special varnish to isolate them from saliva. The patient is recommended not to eat or drink for 2 hours. Fixing bridge is based on the same principle as crowns. Depending on which of the structure is taken as a support, there are some difference in their fixing with cement. There are features that are inherent in the method of fixing only bridge. They are related to the fact that for bridge it's necessary to simultaneously strengthen 2 or 3 and sometimes more crowns located at a certain distance from each other. Therefore, it takes more time to decrease and dry your teeth, although the duration of the cement curing remains the same as when mixing it for a single crown. The most common complications are fixing bridges, increased bite, and cementation of supporting structures. The increase in bite occurs due to the fact that the excessively hardened cement is not fully squeezed out from under the crown, and the crowns are cemented because saliva gets into them. Thus, good isolation of the supporting teeth from saliva and rapid application of bridge are the main conditions for the successful implementation of this manipulation. If after fixing the bridge prosthesis a separation of the bite outside the bridge is detected, the prosthesis must be removed immediately and the described manipulation repeated again. Mistake in the replacement of dental defects with bridges. The most common errors are following. Incorrect assessment of the clinical condition of the supporting teeth is always the result of a superficial examination of the patient, in which even gross changes in the periodontum can be seen. In teeth, if there are fillings, color retention, and stability, the pulp may be necrotic. The hermetism created by a complete crown can cause serious complications immediately after applying the prosthesis or after some time. Therefore, teeth with fillings, in addition to the radiological control, should be checked by electro-odontometry. The expansion of indications for bridge takes place when the pathogenesis of the developing pathology or the nature of the disease is not taken into account the relationship of bridge with the tissues of the prosthetic bed, which in this case is periodontum. Increasing the height of the bite on bridges is a gross mistake, which is not difficult to notice. The other mistake relates to the breaking the contact between the artificial teeth and their natural antagonist. The functional efficiency of such prosthesis is low. Mistakes made when modeling the body of a bridge prosthesis are to create overly pronounced chewing bumps, the lack of sufficient area of junction with the crown, which often leads to the separation of the body bridges and damage the mucosa. This is essentially a group of technical mistakes. Technical mistakes include poor adhesion of parts of the prosthesis, poor casting, which may cause the prosthesis to break down. Gross mistakes include deformity of the prosthesis in spike time. In this case, the prosthesis cannot be placed on the supporting teeth. Either it's balanced or the artificial teeth don't articulate with their own antagonist. Technical mistakes should also include thinning of crowns after their careless bleaching or polishing. The metal of such crowns quickly wears out. On the mounts of chewing teeth or cutting edge of incisors, there are areas with the exposure of hard tooth tissues. A prosthesis with crown defects must be removed.